Not worth it. But he didn't make two mac and cheese once.
All three of your fingers in the.
Do you put all 3 fingers into the bowling ball? It's a weird question.
They do love.
That your girlfriend is my friend's babe. That was my little. That was hilarious. They just.
Okay. Oh, what happened? Might have to switch over.
They are.
Alcohol, legit. What a good topic. What do you want to know? Fine, you win. I'll do it your way.
No, but I saw. Dude, they're.
Running on with I need to get gas. No. Oh my god.
No. 0.
Nobody like really look No, I got
Okay. Dismiss. Hey guys. I had to switch from my laptop to this computer. Not super excited about it. We're having a lively conversation about mac and cheese. I'm interested what your viewpoints are on mac and cheese. Do you have viewpoints about mac and cheese? Yeah, it's a very contentious thing.
Yeah.
How do I zoom? How do I zoom? That's really good.
They're like so bad. They're yeah, but if they win, they're going to get it. It's like they play Virginia. One of those, yeah. Crazy.
Did you go back to George?
Yeah, to Denver. Yes.
But did you go through Georgia too?
Yeah. It's a long beach.
That's rough driving. I was before back this weekend. Yes. What? It was cold. It was like you come. I had a friend give me a hard time because I was drinking iced coffee this morning. I was like, well, it's 20 below where I was at this week. It was. This is literally just you're just holding down the fort. You'll have to text them and be like, she gave me massive extra credit for sitting here by myself. You should have been there. Okay. PK is suffering. PK is suffering. Yeah. Suffering.
All right.
It's gonna be okay. No. Sam, if you go down to Lolo and then go across that way. Yeah. And those are like,
Okay, sweet potato. It was dry. There's a stuff. Oh my God, I didn't know. But it's
okay, so you don't like mac and cheeses that are made with a roux is what I hear.
yeah, yeah, my brother had loved it, so I'm fine. Yeah, and then when you reheat it, it's like, we don't have to bake it. My brother could get like,
Something I love so much.
I'd rather have crap on.
I love Kraft out of the box.
Are you a Velveeta or a Toronto?
I love both, but I think Kraft has a stronger because this is not that we were bored, but like Velveeta was the base of mac and cheese, and Kraft out of the box was just like your everyday like it's Friday and my mom doesn't want to.
I think that you will change.
Absolutely. That's why I love the coffee that they do at the pig.
The noodles.
It's in the noodles, and that's important. Yeah, or not. Rotini would be good for that too. Okay, you guys ready to do this?
Let's do it.
Let's do it. Okay, so let's talk about what we got coming up here, right? Last week, Taste of Freedom here. We just had it. It's hot in here. Huh?
It is really
It's kind of warm in here. Okay, so we will have lecture today. We have lecture tomorrow. We have lecture on Wednesday. Thursday will be probably poster viewing. We'll see. I'm having to negotiate with our 300 folks, and I don't think they want to give up that time. But regardless, we'll do a poster viewing with mac and cheese.
Yes.
It is just going to be a matter of whether or not there are P1s there, which I don't know how much you guys like.
I don't mind.
Okay. Well, regardless, one of the days this week we will have a poster section / mac and cheese feast.
Yes.
Okay. You're like, I don't care about P1's mac and cheese. It's like, you know, I'm kidding. Okay, so I'll print all of your posters off as long as you have submitted them to Canvas, as long as they're all in the same template that I provided you, because that shape is what's important, or that size is what's important. Okay, coming down to the final, which is next week. Approximately half of the final will be cumulative, and the other half will be over the material that we've covered since the last exam. The material that is going to be cumulative is literally just going to be drug names, indications, and MOAs. And I think I have a list of 40 drugs right now that could be possible. And I've put together a study sheet for you. And I was going to show it to you, but I got the green screen to death up here. So I'll post it later today. Okay. And in the meantime, I will also start to put together the study guide for you that you guys have enjoyed in the past couple exams for the material that we have covered since the last exam, which has basically just been like 2 weeks worth of material. We're going to go over alcohol today. That kind of ends neuropharm for us for the semester, which has been a majority of the semester. And then we'll probably do 2 lectures over some like sex hormone stuff, most likely. Does anybody have any questions? Yes.
You might have said this, or maybe it's in your syllabus, but is it like a 60-40 split, a 50-50 between like punitive stuff and new stuff?
I think it's probably going to be a like 60-40 split. But I should probably look at my syllabus to see what is captured there. With like 40% of it being like cumulative, and then the 60% being like the new material. Laura, yes, follow-up question.
You might have also said this, but about how many questions are expected?
That's again something I have to refer back to the syllabus and then do the back calculations. I'm assuming it's probably 100 points, maybe 150 at the most. But it's not going to be any larger than any of the other exams we have taken this semester. Ellie, do you have a question?
Sorry, I don't know if you already said it, but compare short answer. What question?
Oh, that's a good question. Votes? Let's do this
No.
democratically. Who likes short answers?
Nobody raised.
Who does not like short answers?
Yeah.
Tell us what the short answer is.
Yeah, those are the questions you know are coming because I just tell them to you ahead of time.
It's like a match.
Matching, probably not matching.
Or like something word or like we do the matches. Like have a pen and then
Are you like
yes.
like the fill in the blank kind of?
Or like we could do like a Nora B like
I loved asking draw the synapse questions. You guys are like, ooh. Maybe how about this? We won't do any short answer, but your extra credit question will be short answer.
that's perfect. Okay. We can do that.
Maybe some type of synapse drawings. What? You've done like 4 of them, right?
No,
We can do
and
all
I was
Yeah.
I like how this is become a negotiator. I'm really advocating my authority here. Yeah. Okay. Well, okay, yeah. So we'll just do multiple choice, and then the extra credit will be a drawing of some sort. Okay. Does anybody have any other questions or concerns at this time? Okay. Okay, well then let's go ahead and get into this. So like I said, our last kind of lecture here is on alcohol. Because I'm guessing like half of you weren't here last Tuesday. Please do make sure that you go back and watch that lecture. It's about cannabinoids and psilocybin. I think I went pretty quickly through it, but I think it's good to know nonetheless. Obviously, you'll be tested over it. So today we're going to be going through alcohol as well. Okay, so we'll talk briefly. There will be one slide on history. We'll go over use, enzymes and polymorphisms, methanol in its relationship to ethanol, short effects of both short and long-term use, stages of addiction, clinical uses, and drug interactions. Okay, as long as there's been humans and as long as there's been fermentation, there has been alcohol use by humans. Roughly the first time it was kind of characterized is about 10,000 BC. 3000 BC, you see ancient Greeks and Romans using it for religious festivals, amongst other things. What's interesting is that it kind of evolved in all cultures at different points. And again, keep in mind, wherever there's use, there's also overuse that can be noted. Keep in mind, when we were talking about the 1920s to 1933, that was our prohibition era in the United States, where it was illegal to drink alcohol. One of the reasons for that being is that they needed a reliable workforce and they wanted to discourage drunkenness. And so at that point in time, it became illegal. Now, alcohol use disorder, or AUD as we'll refer to it moving on, is one of the most prevalent psychiatric disorders worldwide and often has comorbidity with various other diseases. And we'll talk about that. Now, what's interesting is I pulled this particular graphic because it's the worst states for drunk driving, and this is Montana. Yeah. I mean, I'm a native Montanan, and I was around when the road beer went away. Oh God, it's wild. Anyway, so when the road beer, did it go away? No. It's gone away. No, but our highest consumption that we see is per event is in the late teens to early 20s. Older adults tend to consume less more often. So with your older adults, you might see like a glass of wine
every night versus kind of the binge drinking that you might see in the teens to early 20s. Americans across the border consume about 2.3 gallons of alcohol per year. And again, the CDC estimates about roughly 10% of deaths in the 20 to 64-year-olds are alcohol related. And again, a lot of those are kind of traffic accident related as well. So you have a third of traffic accidents are alcohol related, costing roughly that 250, almost 250 billion here. So you can see here again, per 100K residents, we do have a pretty high rate of drunk driving in the state of Montana. Okay, so ethanol consumption. So relative to other drugs, quantities are far kind of larger to consume to get said effect. So when we are kind of evaluating the effect of like one drink in terms of fluid ounces or ounces, that would be 12 ounces of beer, 4.5 ounces of wine, or 1.5 ounces of 80 proof alcohol. Those are all considered one drink. And so the way that we evaluate once somebody has consumed said alcohol and the amount of alcohol that they've consumed is via their BEC meter or their blood ethanol content. And this is expired levels of ethanol. And so when you've seen individuals who've taken, like, let's say, a breathalyzer, this is essentially what they are measuring. The legal limit is 0.08 or 80 milligrams of ethanol per 100 milliliters of blood. So one drink for a 70 kilogram person would produce a BEC of 0.03, and many factors kind of can affect your BEC. The rate of what you're drinking, the gender, the body weight, water percentage, stomach emptying, how much other food you've consumed, as well as that particular person's individual metabolism. So again, this is one of your blood ethanol content graphs. Again, this on your y-axis gives you the number of drinks. Your body weight shown in pounds here is on your x-axis and gives you kind of where they are going to see impairment for, let's say, driving skills. Again, if you were like, let's say, had 3 drinks and you're a 120-pound person, you'd be considered legally intoxicated at that point in time. Okay, so here's a question I have for you. If you are following along in the PowerPoint, maybe find somebody who has the PowerPoint pulled up. Janice is a 160-pound female who consumed 4 beers 2 hours ago. So my questions for you are, what is Janice's current BAC? Should Janice currently drive based off of where she's sitting at? And will it be safe? When will it be safe? Like, how much time will it have to elapse before she might be able to drive? So I've embedded a BAC calculator in here. So you're just going to go ahead and click on that link. And from that link, you should be able to put in the information that's provided here. And you should be able to answer all of these questions. So again, if you have the PowerPoint pulled up, click on that link and then start putting that input in there. So if you don't have a device, find somebody who does. Go ahead and pair up and answer these questions. Not probably fine. 160. And then she had how many? We said 4.
Yeah,
You gotta look it to female.
Female, 160, 2 hours.
But it's almost.
Okay. Okay, so yeah, so if you put in for a female who has is roughly 160 pounds, has had 4 beers over the past 2 hours, you can see kind of the projection here of the blood alcohol content. Currently, hers is at 0.089, basically 0.09. So it wouldn't be legal for her to drink. You can see, or I'm sorry, it wouldn't be legal for her to drive at that point in time. If you look at that 1 hour pass, it's still at 0.1. Roughly at 2 hours past this point, you'd be at that 0.89. You're roughly at the 3 hour point, you're getting 0.07. But there still probably would be some cognitive impairments seen at that point in time. Again, this I think is just an interesting tool to know that exists out there. And so I just wanted to kind of bring your attention to it for a moment so we could calculate this. So should she drive? How long should she wait till she can drive? Like an hour, probably more, honestly, based off of that level. Again, you don't want to have any of that cognitive impairment kind of hanging around. So when we talk about ethanol, again, kind of as a drug, keep in mind it's a very small molecule. We'll talk a little bit about its mechanisms of action. In terms of administration, more often than not, it's orally administered and it's rapidly taken into the bloodstream, again, because of that small size. Via stomach and small intestine, keep in mind that the presence of food helps slow ethanol absorption. So it's one of the reasons when you're coached through kind of healthy drinking habits, not drinking on an empty stomach can kind of slow that rate of absorption. Metabolism, again, you're seeing first pass metabolism by gastric and liver alcohol dehydrogenase, and we'll talk about these liver enzymes here in a second, just because they're really important in terms of the SNFs that are sometimes carried with them. And again, this can decrease the BECs that would be seen via IV. Again, you're slowing that rate of absorption by orally administering it, but if you administer via IV, obviously that you would see a much higher level, circulating level of ethanol. Metabolism is affected by, we'll say, sex, and aspirin inhibits ADH in men. So for our metabolism, there are a series of liver enzymes here that are worth knowing. We have ADH, which is alcohol dehydrogenase. So again, the first step in this process is that ethanol is consumed, and once it hits the liver, it's going to be metabolized by alcohol dehydrogenase, or ADH. From that point in time, your products can be acetaldehyde or formaldehyde. Acetaldehyde, you can see here, is going to be further metabolized by aldehyde dehydrogenase, and so that makes sense. Alcohol is metabolized by alcohol dehydrogenase. Acetaldehyde is metabolized by acetaldehyde dehydrogenase, and that's going to result in acetic acid. A couple of things I'm going to point out here is, in terms of metabolism, alcohol dehydrogenase is probably the predominant enzyme that is going to metabolize ethanol, but you also have CYP2E1 as well as catalase that will also help with the metabolic process. And that with each cycle of this enzyme, you're also seeing the use of NAD+, and that's going to be important later on. You guys have probably heard of NAD+ and other metabolic cycles, right? You guys had to learn all those metabolic cycles in biochem. When and how do we use NAD+?
The Krebs cycle.
The Krebs cycle. Yes, the Krebs cycle.
I don't know what it is, but I know that.
There you go. That's good biology education there. It's there. You're like, I know every step of that cycle. But yes, but if you don't have that NAD+ available for the Krebs cycle, we'll see how that kind of shifts metabolism into different places. So each step requires that 1 NAD+, and 1 mole of ethanol requires 3 moles of NAD+. So it exceeds that 1 in liver and limits ethanol metabolism to kind of 8 grams per hour. So without that NAD+, the metabolism can't take place. And so we'll kind of see how that shifts things through the steps in this process. We're starting to also, this figure is really great because it also identifies some of the drugs and drug targets here. So disulfiram is going to alter aldehyde dehydrogenase, which leads to a greater buildup of some of these precursors before they've been completely metabolized that tend to have some pretty icky effects. So what we do is, if somebody has alcohol use disorder and we treat them with disulfiram, they're basically just going to immediately get some of those terrible kind of hangover effects without kind of the euphoria and the dopamine rush that you get associated with alcohol consumption, because you're creating a larger repository of these precursors prior to them getting fully metabolized into things like acetic acid. So we'll talk about that a little bit more moving forward as well. So the liver limits the rate of ethanol metabolism is at NAD+. It's going to, when NAD+ enzymes are impaired, you're going to get an accumulation of lactic acid, reduced activity of the TCA cycle, and accumulation of acetyl-CoA. Okay, so given what you know about the citric acid cycle, which hopefully this isn't a trauma response for you guys, but yes, we have the citric acid cycle here. We have our inciting kind of precursor molecule, acetyl-CoA, and as it combines with, again, some of those smaller carbon molecules and starts to undergo this series of reactions, you can see NAD+ is utilized here in a couple different parts of that reaction. So if this is not available, this can't be used for this cycle, right? And so we get a larger accumulation of acetyl-CoA, reduced activity of the turn of this, And so it's going to affect your whole metabolic cycle. So what it's going to result in is what we call lactic acidosis. That's going to increase the amount of NADH, as well as the elevated acetyl-CoA and increased fatty acid synthesis. So here we can see ethanol consumption, again, using that NAD plus, that is later converted to NADH. So you're getting an increased amount of this available that isn't able to be utilized in other cycles that leads to the production of acetaldehyde. You'll see an alcoholic ketoacidosis. This is also, again, altering that NADH balance, as well as increased glucagon and decreased insulin. And this is going to lead to ketogenesis and exacerbate that lactic acidosis. And so you're getting this accumulation of both triglycerides as well as ketones. And that's kind of part of the negative side effects that are seen downstream with alcohol metabolism. So we talked a little bit about alcohol dehydrogenase here. The other enzyme that I quickly mentioned was that CYP2E1, which is roughly only going to metabolize about 10% of ethanol. Now, it is induced by chronic ethanol consumption. Therefore, other substrate clearance might be enhanced. So CYP2E1, if you have other drugs that person is consuming, but they're also chronically consuming alcohol, you might see an increased rate of metabolism in those particular patients. And they do also see elevated NADP plus, which you can kind of see that's occurring on here. This is a set of reactions in which you have NADPH and then NADP plus that's being created, along with a lot of reactive oxygen species that are going to create things like oxidative stress, which again, oxidative stress generally isn't great for cells. So when we start to talk about maybe some of the side effects associated with chronic ethanol consumption, you're like, yes, obviously ethanol is binding to this receptor or that receptor, but then you also need to think of some of the toxic byproducts that are also being created. So again, it makes sense as to why you might see increased incidence of rates of specific types of cancer associated with ethanol consumption, is because you're causing those cells that are in contact with quite a bit of oxidative stress. And again, that could be part of what leads to kind of kicking those cells over into a more cancerous state. Sorry, I'm gonna hide this. Okay, so when we talk about alcohol dehydrogenase or ADH, there are a series of SNPs there. What is a SNP? We'll make it really easy for you this Monday morning. Okay, and we care about those why? Because Liz talks about them. Because if you do have a single nucleotide polymorphism, it can alter the function of the protein that is being encoded by that gene, right? So in this case, we have alcohol dehydrogenase, and with the mutations that are carried for alcohol dehydrogenase, you can see that there's a strong association with alcohol dependence found in ADH4 gene. The SNP ADH1B is in a high prevalence in East Asian populations and may protect against alcohol use disorder. They tend to be faster metabolizers of ethanol. The SNP alcohol or aldehyde dehydrogenase, which is ALDH2-2, has a higher rate of esophageal cancer if those individuals choose to drink. And then this ADH1B-3 in African Americans displays a lower risk for heavy drinking and ethanol-related problems. If you look down here, there's kind of this very small link. If you're interested in SNPs in alcohol dehydrogenase, that actually links you to a review article that talks about all of the different variants that have been characterized, leading to different metabolic cycles for alcohol dehydrogenase. Okay, so these SNPs are important. You also see them implicated in alcohol use disorder, as well as the more efficient aldehyde dehydrogenase. That's what we're seeing right here. So low levels of acetaldehyde are rewarding, and high levels have toxic side effects that we have associated with alcohol consumption. So if aldehyde dehydrogenase is in fact non-functioning, you get high levels of aldehyde that have toxic effects, and again are going to mimic some of the maybe not so great side effects of consuming too much alcohol in those instances. And so you can either target that pharmacologically using disulfiram, but as we'll see here, there are in fact some populations that carry SNPs that basically create non-functioning aldehyde dehydrogenases. So about 10% of the Asian populations are homozygous for this ALDH2-2. If they drink a single drink, they tend to have a pretty severe reaction in that case. For the 30 to 40% of the Asian populations that are heterozygous, you just generally see enhanced sensitivity to alcohol. I don't know what 22 is. I think my cat stepped on the keyboard. I apologize. It's not a trick. But yes, so the differing functions of aldehyde dehydrogenase are going to alter the metabolism of said alcohols, and again, can lead to some pretty unpleasant side effects, even with low amounts of ethanol that are consumed. Okay, so this is again the metabolic cycle for ethanol. Keep in mind here, a similar substrate for alcohol dehydrogenase is methanol as well. We're showing that in red. And so interestingly enough, we'll see that alcohol actually has a pharmacological treatment utility if you have somebody who is suffering from methanol poisoning, because the reason methanol poisoning is toxic is because the byproduct of that is formaldehyde, and the accumulation of formaldehyde is not great. What do we use formaldehyde for? Preservation, right? And so you can't imagine it's going to be great for living cells. Okay, so in this case, if you have somebody who's consumed methanol, if you treat with ethanol, you can compete the alcohol dehydrogenase. So it's primarily metabolizing the ethanol and not the methanol to lead to the production of formaldehyde. So we'll talk about that here in a second. Now, methanol is not for human consumption. It is used in industrial solvent found in paint remover, shellac, and antifreeze. If you go into like any of the labs here on campus, you guys have probably seen this in like your pharm sci lab. We have bottles of ethanol, right, to disinfect surfaces. But any lab grade ethanol is going to have methanol added to it so people do not consume it. As little as 10 milligrams produces toxicity in up to 12 hours. And the symptoms generally are going to present as headache, GI distress, pain, difficulty breathing. Again, you're going to get severe metabolic acidosis from formic acid accumulation and can result in kind of severe respiratory distress. Now, what was interesting is that when we were during COVID, when people were using a lot of ethanol that again was not intended for human use, that ethanol would have some amount of methanol in it, and it is something that can get absorbed transdermally. And so you saw people with some kind of low-grade methanol symptomology associated with that, just because they were putting basically hand sanitizer on so frequently that some of that methanol was getting absorbed across the surface of their skin. As you can see here, methanol is metabolized by alcohol dehydrogenase. So by utilizing either one, this drug up here, which is not going to have the same effects as ethanol, but ethanol, like I said before, if you treat with ethanol during methanol poisoning, you're going to all of that alcohol dehydrogenase is going to be focused on metabolizing the ethanol, and you won't get that shift of methanol to the formaldehyde and later formic acid byproducts. So the ADME treatment of methanol poisoning, again, the administration there would be oral inhalation skin, takes about 30 to 60 minutes, and again is metabolized by alcohol dehydrogenase to formaldehyde and then later to formic acid. The treatment of poisoning, again, as I said earlier, is competing with ethanol for alcohol dehydrogenase. It's used to lessen the formic acid production, and again, permisolol is also going to be possibly used to inhibit alcohol dehydrogenase, but don't also treat with that particular drug and then consume ethanol, because you're just going to prolong the half-life of alcohol, since it's not going to be metabolized by alcohol dehydrogenase if you're inhibiting it with the other drug. You can also treat with the sodium bicarb to essentially combat downstream acidosis as well. I will say in the past, the way I've given exam questions about this is sometimes I'll give you a case study of a lab assistant who's consumed the alcohol in the lab. Say, what would you use to treat this? And so here are kind of your two answers related to that question. In terms of mechanism of action and what ethanol does, it does act as a CNS depressant. In moderate amounts, you see it acting as an anxiolytic and disinhibitor of certain behaviors. Can lead to uncontrolled mood swings and emotional outbursts in large amounts. It's essentially going to mimic anesthesia. Here you can see kind of the BAC levels and the clinical effects that you might see associated with them. Again, at lower BACs, you're seeing sedation. Higher, you're going into like emesis, and anywhere from 300 to 400 milligrams per deciliter, you're seeing coma, and later even maybe respiratory depression and death. We talk about the short-term effects of ethanol. That's going to be dictated by a lot of Other confounding variables, things like body weight, consumption, rate of consumption, and absorption of the GI tract. At low concentrations, you will observe things like giddiness, muscle relaxation, and impaired judgment. Middle concentration, slurred speech, lack of coordination, unsteady gait, and at high concentrations, you might start to see vital signs start to be mitigated, coma, and even death. Again, symptoms are going to be exacerbated at lower concentrations if taken with other depressants. So give me some examples of other CNS depressants we've learned across the semester. So what, you said benzos?
Yes.
Yes, I feel like that's always a go-to, right? Benzos. Are there any other types of drugs that we discussed that are going to increase inhibitory tone? Barbiturates as well. Kind of anything that's acting at that GABA receptor in like a positive allosteric modulatory way, they're probably going to also exacerbate the effects of ethanol as well. We'll talk more about where it's hitting here in a second too. So in acute intoxication, again, it just depends on the severity of kind of the CNS depression that you're observing here. You might just carefully observe an individual versus intubating them to make sure they're having, if they are having respiratory effects, that they're still able to get air through intubation. Stomach lavage or stomach pumping. The ER protocol is going to be to observe them anywhere from 4 to 6 hours, again, just depending on the severity of CNS depression that was observed when they were brought in. Okay, so ethanol sites of action. So this would be essentially equivalent to the mechanism of action for ethanol. It is an incredibly small molecule. Keep that in mind when we're talking about this, which means that it probably has multiple mechanisms of action, a little bit kind of like lithium in that way. I'm not saying it has the same like effects, but I'm just saying because of the size of the molecule, you're seeing multiple different proteins being able to interact with. But big picture here, it enhances inhibitory and depresses excitatory or antagonizes excitatory. So I generally see it represented as being kind of an enhancement of that GABA A receptor. So not too different from like your benzos or whatever. You're seeing an enhancement of GABA A. You're seeing glycine, which is also an inhibitory receptor, being enhanced. You're seeing NMDA receptors being inhibited, nicotinic receptors being enhanced. 5-HT3 receptors are going to be enhanced. You have inwardly rectifying potassium channels that are enhanced, which are going to cause, again, inhibition for the cell itself. Voltage-gated calcium channels are going to be inhibited, and kind of, again, these long conductance calcium and voltage-activated potassium channels are going to also be enhanced. So really, as many mechanisms as you can think about for either increasing inhibition and decreasing excitatory action are going to be kind of the end result of ethanol. Okay. This is a video showing
neuroscience. I
Let's
explain
put it this.
neuroscience topics in 2 minutes or less. In this installment, I'll discuss alcohol. How alcohol acts in the central nervous system is still poorly understood. 2 of the best known effects of alcohol, however, are its actions on GABA and glutamate receptors. Alcohol increases GABA activity at a subtype of the GABA receptor known as GABA A. The mechanism by which this occurs is still not clear, but it is thought that alcohol may act as a positive allosteric modulator, meaning it binds to a site on the receptor that is separate from where GABA binds, and increases the effect GABA has when it binds to the receptor itself. The immediate effect of this action typically is the inhibition of neural firing. Alcohol also inhibits the activity of glutamate receptors. Again, the mechanism for this is not fully understood, but because glutamate is generally excitatory, inhibition by alcohol initially leads to the reduction of neural activity. A long list of other synaptic actions have been linked to alcohol, including but not limited to activation of serotonin receptors, enhancement of glycine receptor function, inhibition of adenosine reuptake, inhibition of calcium channels, activation of potassium channels, and modulation of nicotinic acetylcholine receptor function. It's not clear, however, how relevant each of these effects are to the human use of alcohol. There are also some large-scale effects associated with alcohol. For example, alcohol stimulates dopamine transmission in the mesolimbic dopamine pathway, an action thought to be associated with the reinforcement of alcohol consumption. Alcohol affects motor coordination and balance, potentially in part through its influence on neurons in the cerebellum. And it inhibits long-term potentiation and other mechanisms of synaptic plasticity in the hippocampus, which may contribute to its memory-disrupting effects.
Okay, so you're seeing a little bit more of mechanism there, a little bit some of the brain regions associated with it. And it did show that mesolimbic pathway, which when you see that mesolimbic pathway, you should think about areas like the ventral tegmental area and the nucleus accumbens, which is kind of our reward pathway for the brain. Okay, those are dopaminergic projections. So any drug that modulates this particular pathway tends to be kind of labeled as a substance of abuse, because humans being humans, they're like, yes, this reward pathway endogenously is great, but if we can exogenously activate it, it has a really high propensity for reward. And so when we talk about alcohol, we'd be remiss to also not talk a little bit about things like tolerance. We'll talk about addiction as well as dependence. In terms of tolerance, again, this is reduced response with the same dose, requiring a higher dose to get the same effect. So the acute effects of this occurs within hours and is just kind of due to CNS adaptation. It's called the Mellanby effect. It was originally characterized in 2017 that there's this perceived behavioral impairment at a specific blood alcohol concentration was greater when the blood alcohol concentration was rising than basically was falling. So basically during that consumption event, you're just kind of, you're not able to correctly perceive the amount of ethanol you've actually consumed. If you look at kind of tolerance in the chronic state, that's very psychodynamic. There are some alterations in kind of cognitive and behavioral responses to ethanol. And again, you also will see an upregulation of alcohol metabolizing enzymes. And so those alcohol metabolizing enzymes are going to start to increase in their own expression. And because of that, you become more efficient metabolizers over time if you're chronically consuming it. Now, dependence related to alcohol can occur from several hours to days. In the case of dependence, the symptoms related to that will be things like motivational change, sleep disruption, autonomic nervous system activation, tremors, and seizures. We talk about dependence. Dependence is often characterized by the presence of withdrawal symptoms. So if you're chronically consuming alcohol, you stop consuming it, these are the types of symptomologies that will probably start to arise. Now, usually 2 or more days after, you might see delirium tremens that start to occur, things like hallucinations. And long term, you might see the presence of anxiety, dysphoria, and even depression. So if we start here at like day 0 of discontinuation of alcohol consumption, the first thing that's going to hit you here is anxiety, insomnia. So maybe you might observe withdrawal seizures depending on the intensity, maybe even hallucinations. And then yes, anywhere at 2 to 9 days after alcohol discontinuation, you'll see things like tachycardia, hypertension, maybe low-grade fever. This is, again, if you think about it from a pharmacological standpoint, if you've been chronically consuming alcohol, you've been chronically consuming a depressant for your central nervous system, right? So in the moments where you start to withdraw said depressant, that's when you see kind of almost like overactivation. That's why the things of like the presence of withdrawal seizures isn't surprising, right? You've been consistently depressing the system. So when you start to take off the brakes, that's how you get kind of that overactivation and seizure genesis that might occur upon, again, that withdrawal. So with the withdrawal kind of negative affect states, again, a lot of what's driving the seeking behavior related to the use of alcohol is this reward pathway that we were just mentioning a second ago, where we have the mesolimbic pathway from the ventral tegmental area to the nucleus accumbens. It's shown here as a series of kind of red projections. It also hits areas of the brain, things like the amygdala, which is one of our fear centers of the brain. And as dependence occurs, this corticotropin releasing factor, norepinephrine and dynorphin, are recruited and generated during strong drug-seeking motivations. Dynorphin, where have we recently heard that word? Yes, it's an endogenous opiate, exactly. So it's an endogenous opiate, so it has kind of those same types of, we'll say, pain mitigation effects if it's released endogenously, but more so, it's also inhibiting those GABA projections in this pathway here and leading to more dopamine release. So that's also a part of, again, the dopamine release that occurs in these instances. You start to see dysregulation of the prefrontal cortex. And again, we don't need to get like deep into the neuro anatomy of all of these. Your prefrontal cortex is just the front of your brain that helps you make complex cognitive choices. So it shouldn't be necessarily that surprising to see some level of impairment here. The GO system of the anterior cingulate cortex and dorsolateral prefrontal cortex engages back to the basal ganglia, which is an area of the brain that we know also has a lot of dopaminergic cells in it. Again, this presents as impairments in decision-making, spatial information, and behavioral inhibition. That's kind of the takeaway here. I don't need you to necessarily memorize every single structure of the brain we're talking about here. you should think about the reward pathway, and again, the prefrontal cortex, which is important for higher level cognitive thought. Okay, so consequences of alcohol consumption, the transient effect that you're going to see here would be presented as a hangover, where you might experience things like headache, thirst, nausea, cognitive impairment. Again, this is a result of ethanol withdrawal, dehydration, and sometimes mild acidosis that's involved with this. You might also experience insomnia. Over chronic consumption of alcohol, you'll start to see brain shrinkage, often associated with things like alcoholic dementia, and we'll talk about again what that looks like here in a second in Wernicke's and Korsakoff syndrome, and reduces brain metabolism as well. As we saw mentioned a moment ago, right, that NAD plus is important for the proper metabolic cycles to occur. So in the absence of that NAD plus that allows for the TCA cycle to happen, you're just kind of consistently shifting your brain to lactic acidosis. This is kind of the normal brain of an elderly person. This is a brain of a person with Alzheimer's disease. Again, you're seeing some larger gaps here in the sulci and gyri. In a brain of a person with alcoholism, you're seeing even larger gaps in those sulci and gyri. So it does lead to cell death over time. It just is a matter of how extent that cell death is regarding the rate of consumption. So Wernicke's and Korsakoff syndrome are kind of the two ways in which we discuss alcohol use disorder and kind of the chronic pathology related to it. In the case of Wernicke's encephalopathy, again, this tends to be reversible. You might just see things like confused state, ataxia, abnormal eye movements, blurred vision, nystagmus, and tremor. So it's interesting, we're seeing kind of like a lot of ocular outputs here, which kind of in some ways makes sense though, because your ocular cranial nerves are right next to many other structures in your brain. Korsakoff's psychosis is irreversible. This is severe anterior grade and retrograde amnesia. We're having severe memory deficits. Most likely the root of origin there is going to be degradation of the hippocampus. Both of them are a result of kind of thiamine deficiency. And again, you can reverse things like Wernicke's encephalopathy with early treatment with IV thiamine. So here you can see kind of Wernicke's Korsakoff psychosis. If you're into mnemonic devices, again, COTRAC would be that for Wernicke's and Korsakoff's specifically. And the adequate treatment of thiamine deficiency in alcohol users, again, your aim is basically to start to hopefully reverse any of the symptomologies that you're seeing observed in the case of Wernicke's encephalopathy. Questions? Okay. Other effects that you might see outside of what we just discussed, you're going to see almost all physiological systems affected. You can see neuroendocrine, from sexual dysfunction to bone, body temperature, diuresis, cardiovascular, stroke levels tend to go up, skeletal muscle decrease in muscle mass and strength, GI and digestive system, you tend to see a higher rate of cancers associated with any of the areas that are in direct contact with orally consumed alcohol, and then cancers of the oral cavity, pharynx, and esophagus, you can see down here as well. So yes, quite a few comorbidities associated with chronic alcohol use as well. Clinical uses of ethanol, kind of going from this is what chronic alcohol consumption does to you as to versus when you might use ethanol as a possible treatment. We discussed earlier the treatment for methanol poisoning as one possible clinical use of ethanol. You can actually use dehydrated ethanol to be injected into the trigeminal nerve for pain. So if you have trigeminal neuralgia, that might be one use for it. Epidural, subarachnoid, and lumbar perivertebral injections are also given for inoperable pain. So this is kind of what the preparation for dehydrated ethanol might look like. And so again, in those instances of pain, if nothing else is helping, these might be possible uses for ethanol. Okay, so drug interactions, anything that's a depressant, probably not a great idea to combine with ethanol. You have to generally a synergistic effect, especially if anything is also targeting the GABA A receptor specifically. But because it does increase inhibitory signaling for most of the other signaling systems, it's also going to not be advised. So anything that metabolizes, so acute administration inhibits the enzymes that metabolize codeine, morphine, serotonin, some benzos, even warfarin. So again, probably going to stay away from ethanol during those particular drugs. I found this particular site, Can I Drink While Taking This? It gives you a kind of a whole set of possible drugs here. You can see Xanax is kind of at the end of don't do it. And then you have things like Tamiflu and Lipitor, kind of a little less risky for co-consumption. As we mentioned earlier, about 10% of ethanol is metabolized by our CYP2E1. So you are going to see increased rate of metabolism if you have a chronic consumer. For that CYP2E1 function is going to be increased. And so you'll see warfarin, propranolol, benzodiazepines are also going to be increased in their rates of metabolism. Okay, there is quite a high rate of comorbidities with other mental health conditions. So patients with mood or anxiety disorders are 2 times as likely to suffer from drug abuse disorder. And then post-traumatic stress disorder, you also see a pretty high rate as well. This particular graph here is again just kind of showing abuse or dependence by drugs and mental illness. We see the abuse of alcohol over here on the far left. This is kind of illicit drugs, abuse of both, dependence on alcohol. But again, keep in mind here as we talk about this, it might in some forms be like a form of self-medication to consume ethanol to reduce the thought processes of maybe more complex cognitive disorders that are going on, things like PTSD. Now, when we talk about alcohol use disorder genetics and pharmacogenetics, we already discussed the SNP distribution and heritability for even alcohol use disorder can be fairly high. Keep in mind, it also can be pretty influenced by culture. There are specific cultures where alcohol use is just part of many celebratory functions. We can see here that other gene variants that could also influence alcohol use disorder. So if you had a SNP that you were carrying and left your opioid receptor, we just a few slides ago saw the release of dynorphin related to consumption of alcohol, dopamine, serotonin, the GABA receptor, the glycine receptor, basically any of the possible pharmacological targets for ethanol. If there's a SNP associated with it, it could alter rate of consumption as well. Okay, so the pharmacology for possible treatments. Disulfiram, again, is going to inhibit your aldehyde dehydrogenase activity. Therefore, if it's consumed, the consumption effects are going to be exacerbated. So we see that process here. So if you're inhibiting this, you're basically going to get an accumulation of acetaldehyde. So that kind of negative effects of that, you're basically kind of lowering the threshold from a lot of those kind of almost like hangover effects that you see associated with alcohol consumption. As I mentioned earlier, you're not getting that initial bump of like euphoria or dopamine release. You're basically just kind of experiencing the kind of the most negative part of that consumption. What's interesting is we also see sometimes naltrexone used for this as well. It is a mu opioid receptor antagonist that reduces craving and decreases relapse. You can utilize a long-acting injection outside of the US, and acamprosate is also sometimes utilized. It's glutamatergic in its nature, and it's been also shown to reduce relapse. Okay, so this is a table just showing some of those FDA-approved medications for alcohol use disorders. Again, we see naltrexone, we see acamprosate, we also see disulfiram, and again, that gives you some of the mechanisms of action, common side effects, as well as kind of relative contraindications as well. Okay, so really quick, there is additional information. If this is something you're interested in, here's a link to the National Institute on Alcohol Abuse and Alcoholism. And again, if not that I'm telling you to go out there and diagnose anyone, but it's AUD is diagnosed when a person says yes or to 2 or more of these questions below. So it's just, again, worth just noticing what some of those questions might be. Okay, so I will leave you there for today. Later today, I will be posting your drugs to know for the final, as well as a review. Is there anything else that you all need from me right now? Oh, the last thing I'm going to plan for you is later this week, I'm going to distribute or have you guys sit and fill out your reviews for said course. So just start thinking, you're going to be seeing this coming through for all of your courses. So just start to self-reflect as to things that you might suggest we change, things that were great, things that could have improved. So just start to think about those things. I take those very seriously, and this is kind of your opportunity to give me feedback going into next semester, because we're going to see each other all next semester as well. Okay, cool. I'll see you guys tomorrow. Have a lovely day. It's nice to see you back, and good luck with your week. It was good. Well,